So welcome to One Slide, One Lesson. In this second lesson, we're going to look at the movement of the joints of the pelvis. In the first lesson, we looked at those joints themselves, and in this one, we're going to look at the movement, so therefore the axis points. So when a joint moves, it has an axis of motion. When a joint is static, it has no axis of motion, because an axis is an invisible kinematic construct, which basically means that it only appears in movements. When there's no movement, then it just doesn't exist. So hopefully you kind of got that concept when you were training, and if not, hopefully this will help today. But around the pelvis there are 8 areas in which there can be movement. So when you bring them all together, it means that there's a huge array of movements in the pelvis. Biggest amount of movements obviously going to be at the hip joints here. So you've got a hip joint on either side where the head of the femur sits into the acetabulum. There's one on the other side as well. Really important joint, obviously. We see patients that have hip joint arthritis or various injuries around the joints, tears in the labrum, damage to the joint surface, or they've even had a hip replacement and it's left them with limited movement or leg neck discrepancy. Massive amount of movement at the hip joint, so it's multi-axial. Actually, all the ligaments around the hip joint, the ischiofemoral, pubofemoral and the iliofemoral, they all attach. Actually, the femur isn't on this diagram, but they all attach on that superior anterior aspect of the greater trochanter. And the reason why they do that, even though they come from different places around the hip joint, is that so they can actually control and limit extension. In flexion, your hip joint is only limited by your torso. You know, if you can bring your leg up high enough, your anterior thigh will hit your chest. But in extension, that movement is controlled by those 3 ligaments. And the reason why it's controlled is because if you have the same amount of flexion as you do, if you had the same amount of flexion in extension, you wouldn't be able to propel yourself forward. So if you did have that full range of extension like you do in that flexion movement, the pelvis would just drop to the floor and it would be very apropulsive. So there has to be controls. There's obviously controls by the ligaments and there's controls by the musculature at toe off, so you can propel yourself forward. And that's why all those ligaments, they actually attach on the front, because they help to limit extension. Between each of the ilia is the pubic symphysis. It's a fibrocartilaginous joint, so it's an amphiarthrosis. So there's a limited amount of rotation there, and also that can soften with elastin during the gestation period, so you can deliver a child through the birth canal. Obviously that doesn't happen in males. So under normal circumstances, when that joint is in union, it allows a little bit of facilitation to other movements around the pelvis. You can get an injury there. I've actually had that injury many years ago, osteitis pubis. Common with people who do unilateral sports where there's more force under one limb, and it creates a subluxation in the joint. And if you got one leg longer than the other. I did mine running on a camber on a running track. On my longer leg up the camber, created so much force it split my pubic symphysis. Unfortunately, very poor blood supply, so it takes a long time to heal. You've got the sacroiliac joints on either side. Actually, I didn't draw around the pubic symphysis, that amphiarthrosis joint, it was there. But either side of the sacrum, where each of the wings, and each wing is made up of the ilium, the pubis and the ischium, you have these sacroiliac joints. Very complex joint, very complex mechanically. There is limited movement, but there is movement. There is movement, or translation in biomechanics terms, or in mechanics terms, in all 3 planes. There's more in the sagittal plane. There's a little bit of upward movement, a little bit of rotation, but we're talking millimeters and we're talking nths of degrees. Actually, in flexion and extension, you get nutation and counter-nutation, so flexion, extension, if you were facing that way. And there's probably 2 to 4 millimeters movement, but that's variable. Depends on hypermobility. I don't think we can say hypermobility any longer, but when you get increased compliance in the ligaments, to use the correct mechanics terminology, you'll get a bit more movement. And often if there's an estrogen spike, you can get a little bit more movement. They can fuse, or they do fuse as you get older in women first because of hormonal changes. You can have injuries there, so you can get sacroiliitis. You can get restrictions, unilateral on one side or bilateral. Normally unilateral, normally right side, normally associated with short leg. When it restricts, the sacroiliac joint has two major functions. One is to absorb ascending and descending forces. The other one is to allow stride length. Really important, again, working with the other axis points that allow stride length. If there is a restriction in one of the sacroiliac joints, you'd obviously see a short stride, so probably limited flexion. They'd land in mid-stance. Beware if you've got an orthotic and they're landing right on top of the arch, you'll say the orthotic uncomfortable. It's because they're not getting the heel down first, so loop to the sacroiliac joint if you have those situations. So you'll reduce the movement in the restriction, you'll have a shortened stride length, you'll have an early heel lift, you'll take more shock, there'll be symptoms around the joint and hip joint and you won't think that it's a sacroiliitis. Do a Gillet's test, do a dynamic Gillet's test on the treadmill with some motion palpation, looking at the movement of the sacrum, and obviously deal with it accordingly. Exceptionally important that both sacroiliac joints are moving well, because if one is restricted, it will upset movements in the whole kinetic chain from the tip of your toe to occipitofrontalis on the top of your head, everything in between, and that movement will be unilateral. So if you're not having that nutation and counter-nutation of the sacrum, and if you're not having that little bit of rotation at the sacroiliac joint, the pelvis will compensate by doing more transverse plane rotation because you're losing the sagittal plane rotation. It'll be more on one side. So if you're seeing a patient and the whole pelvis is moving down to one side, loop to the sacroiliac joint, the problem might be there. You've got the lumbosacral union where the fifth lumbar vertebrae sits on top of the sacral promontory here. There's a spongy disc, another fibrocartilaginous joint, another amphiarthrosis. It allows a little bit of shock absorption, a little bit of movement in that disc. Exceptionally important. There's tons of nerves coming either side of the vertebrae and through the sacrum, through the little apertures at the back. They come from the spine and through the apertures to form the sacroiliac joint. Sorry, to form the sciatic nerve. Sorry, it's been a really busy day. So obviously you've got the obturator nerve and femoral nerve in other areas, but out the back it's the sciatic nerve, and they come through all those little apertures. So really important, you have sacrum sitting nicely in the frontal plane, everything's moving nicely, because you can get sciatica. You can actually get sciatica through this greater sciatic notch. The sacrospinous ligament sits here. Sacrotuberous ligament is a little bit longer, a little bit more curved, joins the top and bottom. The top part of that is the short dorsal sacroiliac joint ligament. Don't worry about these ligaments, I am going to talk more about them in the future. And finally, to finish off the slide, you got these facet joints here. That's where the fifth lumbar vertebrae sits on top of the sacrum. There are facet joints between many of the vertebrae as they stack one on top of the other through the spine to give you those lovely three curves: lumbar lordosis, thoracic kyphosis and cervical lordosis. They allow you to do shock absorption. If the spine is very straight, you won't get less shock. If the spine is bending in the frontal plane, you're going to have a scoliosis. An idiopathic scoliosis is more like a snake. Will need some serious surgical intervention. But a functional scoliosis, leaning away from a long leg, as long as there's movement in the spine, you can correct that quite easily as a podiatrist with your orthotic therapy and a raise on short leg. But these facet joints allow a little bit of sliding movement because those vertebrae rotate. They have a little bit of forward and backward rotation, a very minor amount. That sliding movement in the facet joints just absorb shock and control the rotation and the movement, so that each segment of the spine is moving individually. So that tiny little bit of movement accumulated together allows a lot of bending and rotation. So extremely important. So to take away from the slide, you're told that the pelvis doesn't have a lot of movement, but between these 8 movement points, so therefore these 8 axis points, as a combination, all coupled together, allow a huge array of movement, and without it there will be dysfunction and abnormal force vectors and joint torque and joint moments that are sent away from the pelvis, and you can be injured in your neck and shoulders on the tip of your toe because this coupling mechanism is breaking down, and because we're multi-segmental, it's affecting forces and force vectors in other parts of the kinetic chain. So any questions, just put it in the comments below. I hope that was okay. It was a bit rushed because it's the end of the day, but I hope you get the gist of what I was saying. There is tons of movement in the pelvis and it is individualistic. Thank you for watching.